or iTunes, welcome. This is only the audio version. If you're listening on YouTube Live, you can put some comments below as well. I'll do my best to answer some of them as long as they're not personal advice, theoreticals are all good and so on, but I can't give you guys personal advice because I don't really know your case, and I don't want to give bad information. We're going to be covering tight hip flexors today. I I have seen many people with tight hip flexors with various different circumstances, but I wanted to debunk uh, some of the thoughts associated to what's going on with it today. Is it torn? Is it frayed? Is it detached? And give you guys some insight of possibly ways to manage the issue, not only just the pain or discomfort associated to it, but also so it doesn't come back when your activities return. Now, I may reiterate a couple times to put the comments below. I apologize for the podcast listeners, but there's people popping in on YouTube, so I want to make sure everyone knows that they can put comments below, and this is the best way for us to answer questions rather than YouTube comments on videos. It's not always the best forum for us. So, tight hip flexors, they tend to happen with many different types of conditions. So they're a sign of other conditions, not the actual symptom generator all the time. So for example, people who have lower back pain, especially associated to low back disc injuries, within a few weeks their hip flexors do get very tight. Doesn't mean the problem is the hip flexor, but it means the compensation is occurring. It's a protective mechanism. Also, people who have hip impingement tend to have overactive or painful hip flexors. People with labral tears as well. I've met people with pelvic floor dysfunction or post-pregnancy who have also had similar issues. And as the story goes, it just keeps getting tight every time they challenge the area or go running or go squatting, etc. And they're getting really tired of it, and they think stretching may be a remedy for it. And for a lot of people who end up having this ongoing issue, they kind of end up wondering, am I doing anything that's damaging this area? And for that reason, sometimes they just stop doing things. I have this discussion many times with the people that I see is that I say, you're right, you may have some merit to think, you have some merit to thinking that you're like damaged in the area. Like it's scary to think that you have something that you could make worse, but let's just consider the circumstances here. Number one, did it bruise? If it didn't bruise, then it's probably not a large tear. Number two, was there any actual trauma or pop to the area? We need load to actually create substantial injury to the muscle. And so, for example, if I were to say, well, I tore my bicep. Well, how? Sleeping. There's no load. I tore my bicep. How? Running. There's not a lot of load. I tore my bicep trying to lift my friend off of a cliff as he was falling. The load is there. So, when there's load associated to it, a lot of times there's a pop. The pop insinuates there's been some type of, whether it be a tendon coming off or like a small fiber tear. It's various different types. The bruising usually gives us an idea of how large the extent of the actual tissue damage is. By the way, I say tissue damage, but it repairs itself most of the time as well. So when you kind of put all those facts on the table and you're like, well, I was running and it got better when I was resting, and when I was sitting down at work it was okay, but I sat too long, it didn't feel really good. But I started walking around, I feel fine, and I started running again and it came back again. Do you think it's torn? Probably not. It started to get better very quickly, the load wasn't there, there was no pop, there was no bruise, and so on. And so again, it's very normal to feel scared about the injury and wondering if you're going to do anything substantially to change to make it worse. Now, back to the original question, should you do things? It depends on how risk averse you are. But if we took a 10-year version of yourself, which was like 10 years, Joe number one, and we have Joe number two. Joe number two says, I'm so scared of this thing, I'm worried I'm going to make it worse, so I'm just not going to do anything. And I've tried all these therapies, they haven't really helped, and I'm just going to stop doing weight training, I'm going to stop running, I'm going to stop all that stuff because I'm not really sure what actually makes it worse. Fast forward 10 years, what does Joe look like? Versus the other Joe who said, you know what, I'm going to try to manage this condition with good advice. I'm going to be active, but also realize when I'm taking some risk. If I started to do a bunch of hip flexor exercises with a lot of weight on my legs, then maybe the load is there. But running, jogging, like it's really not that, the load's not there. It's okay. What does this other 10-year version of Joe look like compared to version 2? The inactive version of Joe has potential risk of other conditions, diabetes, heart conditions, etc. They're generally inactive, they're sedentary, which carries its own inherent risk. And then the active version of Joe, even though he may still have some pain and discomfort, he has this problem come up once every year when he really trains for a big event. Overall, this version of Joe is actually easier to manage. They're less scared. Mentally, they feel better. And physically, they're in better shape, even though they still have some aches and pains going on. The inactive version of Joe, all they really did was they took the load, the load and the strain away. Naturally, it makes them feel better, but when they go back and do things again, they may notice that it comes back again. Because 10-year version of Joe, who's inactive, is probably going to say, I'm tired of this. I remember I used to be really fit and I was really active, and I think I'm going to go run again. Dang it, that came back again. And then there's less experience with dealing or managing the discomfort or pain and actually finding ways to be active despite of it. So I tend to think that the active version is a way better option. As you can tell, I'm a fan of that. I don't think inactivity helps with many different things, but also it doesn't necessarily, it's not a way to treat or manage the pain, but it does help manage the individual even better. Things that cause the tightness in the first place, again, they can be protective mechanisms of other types of conditions, hip impingement, low back disc injuries, labral tears, and so on. Even old knee injuries or foot injuries, plantar fasciitis can be a part of it, since it works the load up the chain. And again, I don't mean load in a way that's like damage it like enough to pop the muscle, but overall it's just more demand in the same activity. There's an analogy out there, I think it was Stuart McGill's analogy, he calls it the butter in the bicep. He said overall the load of the butter really is not that much, it's not enough to pop the bicep off, but holding the butter in your hand flexed for like 3 hours is going to be murder. And that is the analogy of just an overactive tissue which has too much demand, even low load over time, and doesn't really give it a chance to relax. So in these scenarios, the options are you take the demand away of the hip flexor by settling down the other problem. So if you have an old knee injury which really hasn't been resolved and you've been avoiding the knee, we need to make sure to strengthen the knee up. If you have an old low back disc injury and you've been avoiding doing things like, say, deadlifting because you're like, it's not really worth the risk and I had that bad experience before, deadlifting with good form helps to build core strength. It does help build strength of the leg as a whole, but more so what it does, at least from a hip flexor analogy or an overactive hip flexor, it actually builds strength of hip extension, which is the opposite of the prime movement of the hip flexor, which flexes the hip. So it builds hip strength in extension, and what it does is it turns off, quote unquote, the hip flexor or the hip flexor group. And so what this is called is reciprocal inhibition. So you guys can look this up if you'd like. It basically means if you contract your bicep, your tricep can't be at full contraction because your elbow wouldn't flex. It's impossible. It's not off per se, but it decreases the activity of it. But you do need some activity of the tricep if you're still doing a bicep curl. But that's why the bicep gets its pump, because it's doing most of the work. If you're doing hip extension activities and building strength of hip extension with, say, a deadlift, with a good formed deadlift, it builds hip extension strength. And you start building the capacity and strength of the hip extensor group, decreasing the use or the demand of the hip flexor group, or with the psoas, iliacus, TFL, rectus femoris, and so on. So that's one aspect. Now, for those of you who have been dealing with like a recent injury, like a low back disc recent injury, like there's usually like a 2-3 week period of time where it's kind of the protection is helpful, and I usually let people just kind of ride with that a little bit until their primary injury settles down, and then we can start working around it and get it settled down. But for those of you who've had an injury for a long time, had hip flexor tightness for a long time, those people may have developed what we call trigger points. Trigger points within the hip flexor are areas that we believe are areas of more density, and they're there as a rudimentary stabilization system. They develop over time, and the adaptation of the muscle to become hypertoned or more tonicity, tighter, if you will, comes over time as well. It's like if you weight train a lot, then you get stiffer in the areas where you weight train. It's an adaptation, happens over time. It doesn't happen over a short time. So those of you who have had it for decades, those people may fare a little bit better towards soft tissue care types of modalities, active release, fascial manipulation, even some self types of care, if done in the correct areas, can be very helpful. I'm not a fan of sticking things like bumpy tools they buy on Amazon into the hip flexor. I don't think it's useful. I think it carries risk. By the way, if you guys don't know already, there are vessels, arteries, nerves, vein that go into the crease of the hip, right where the hip flexor tendon goes down and attaches to the femur. So, I mean, if it has a pulse, don't rip on it. You know, like it can be very sensitive, and can be very painful, and it can leave some lasting impressions if you do it poorly. So, usually seeing a professional for it is best. There's other muscles around the area too, which may be helping the hip flexor do part of its job when the hip extensors are offline as well. The QL muscle, the quadratus lumborum, is one of them, which tends to explain a lot of the low back pain associated to hip flexor conditions as well. The TFL, which is the tensor fascia lata. There's the rectus femoris, even the adductor group. A lot of them do help out in this process as well. So in these scenarios, we call these the tonic group muscles. The tonic group muscles tend to help more in scenarios where there's poor stabilization, old injury or current injury, and they have more mitochondria. They have more energy. They tend to last longer. In like say when you're running. And they're more willing to help in these scenarios. So you can look up tonic group muscles if you like, tonic versus phasic, and you'll notice that they're all the muscles that you want, that when you go to the doctor and you're like, these muscles are tight, it's always those ones. And so tonic group muscles are the helper groups, but they're not supposed to do all of the motion. Phasic, if you look at them, the glute max and the rest of the quad group and so on, they're the movers. Their primary function is movement, developing power and strength and so on. The tonic group is postural, and so they're not really supposed to be doing all this work, at least in such high frequency. So there's, just to reiterate some fine points here. Number one, if you're having hip flexor tightness and it's ongoing, there's a possibility it's compensating and helping for another condition which is currently active that is protecting. Low back disc, hip impingement, etc. You need to see a good doctor who can actually examine you to find these things out. We have telehealth sessions where we can do this for you if you'd like. We're licensed in different states, 714-502-4243, or a link is in the description for the podcast as well. But there's plenty of people around who can do it if they know what they're doing. If you just got to trust them and go through the process. The second thing is that if you have had it for a long time, there's a chance that you no longer have actually problems that is protecting for. It's just kind of hanging on, and it's really not going away because it has a habit of staying around. There may be a chance more that you would respond to tissue work, but also hip extension strength. That would be good form deadlifting. And I know that with not just deadlifting, hex bar, pin pulls, good mornings, band and bridges, etc. So there's a lot of things that can be put in a program based upon your abilities and your physical literacy, like your exercise literacy, how much you've been in the gym. Even sprinting can help out with it, at least in the long term. So there's plenty of things that can be done that don't have to be necessarily weight based. But as I've mentioned before to a lot of people, that they get overwhelmed with this idea like, oh, I gotta do all these workouts and exercises to feel better. Like, I don't have time to do like deadlifting every day. You don't have to. You don't have to. Like, weight training as a means to feel better and mitigate risk of problems coming back comes down to good old fashioned strength conditioning that most people should be doing anyways. Like I think the standard, at least in the U.S., is that what is it, 10,000 steps a day, just for general mobility. I've heard the saying, move every joint every day. I think that's a great saying as well. Then at cardiovascular fitness, remember cardiovascular, which is pulmonary, and heart is like 120 or 100, I think it's 150 minutes of elevated heart rate a day. That is not weight training. And then strength training or resistance training is about 2 days a week. That's kind of what it is. I know that we don't have time for it because we have busy lives and jobs, but if we expect more from our body, it kind of needs things to thrive off of. And it's not really fair to ask it to feel better if you're sitting in a 40-hour-a-week job and you don't do the other things to help out with some of your problems. So I hope this was a good podcast for you guys, and you come back to the YouTube channel, look at all of our other free content on there. We have tons of long format videos. I don't know if the short view for people know that, but our long format videos are actually way better and more organized than the short ones. So see you guys next time. If you need help, 714-502-4243. Our contact is below. Take care.